Good evening, all, and welcome to this session on the World's AIDS Day. So, the theme of this year's World AIDS Day is Overcoming Disruptions, Transforming the AIDS Response. We have come a long way since 1984 when we first diagnosed or identified HIV/AIDS as a public health threat. A lot of improvements or advancement has occurred in this particular branch of medicine. Now HIV has become a chronic manageable disease, like you say, like with diabetes mellitus or hypertension. And HIV patients can lead a life with a quality of life that is same as that of any other individual. They have a life expectancy almost the same as that of any other individual. That is the situation. But the stigma is still there. There are a lot of patients who present in late stage with complications. So the awareness has to go up. Now, here we have the World's AIDS Day quiz. Well, we'll just look at some of the important aspects of HIV/AIDS. So, I have 10 questions. 432 of you have answered these questions, of which 5 have made all the answers right, actually. So that is a great thing. So, let us go ahead. So, the first question was which antiretroviral class is not active against HIV-2 and therefore should not be used in HIV-2 infected individuals. The options included integrase transfer inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, and nucleoside reverse transcriptase inhibitors. So I'll just check if somebody is answering in YouTube. Wait for the answers. So here, if you look at this particular question, is regarding the difference between HIV-1 and HIV-2 regarding treatment response. Now, I suppose like in this table is quite visible. This basically compares two of these viruses, that is HIV-1 and HIV-2. Now, if you look at HIV-1 and 2, phylogenetically, if you look at the HIV-1 actually originated from chimpanzees or gorilla, whereas HIV-2 originated from sooty monkeys. Now, HIV-1 is responsible for more than 90% of the infections in the world. It has worldwide distribution and is a primary driver of the global HIV pandemic. On the other hand, the HIV-2 is originally confined to the West Africa, from where it has spread to other regions like European countries like Portugal, but it's geographically limited. So HIV-1 is a major cause of the world HIV, like the AIDS pandemic, whereas HIV-2 remains limited to certain geographic areas. And HIV-1 is more common or it's worldwide because it's more transmissible. The infectiousness of HIV-1 is much more than that of HIV-2. HIV-1 also causes higher viral load, also low CD4 count when you compare it with HIV-2. So there is a faster progression to AIDS, HIV infection, when the immune system actually breaks down, reaches a stage called as AIDS. So this progression towards AIDS is much more faster in HIV-1 compared to HIV-2. Now also there are subtypes of HIV-1, M, N, O, P, and group M has subtypes A to K. So this is a groups and subtypes, of which you look at what is driving the world, the global HIV pandemic. It's the HIV-1 group M and subtype C. So this particular group M subtype C is responsible for the global pandemic, and this is the most common subtype or group which is in India as well. On the other hand, HIV-2 is divided from group A to H. Now coming to what matters to this particular question. For HIV-1, all these agents, including NNRTIs, enfuvirtide, fostemsavir, are normally active, including apart from the other agents like NRTIs, protease inhibitors, integrase inhibitors, etc. On the other hand, HIV-2 is intrinsically resistant to NNRTIs, non-nucleoside reverse transcriptase inhibitors like efavirenz, nevirapine, doravirine, rilpivirine, etc. Enfuvirtide is a fusion inhibitor and fostemsavir. So these agents should not be used for the treatment of HIV-2. So that is a question that has been asked here: which antiretroviral is not active against HIV-2 and should not be used in HIV-2 infected individuals? The answer here will be non-nucleoside reverse transcriptase inhibitors, because HIV-2 does not have, these drugs will not act on HIV-2. On the other hand, integrase transferase inhibitors, the protease inhibitors, and NRTIs can act both on HIV-1 and 2. The second question is a clinical question. Is a 34-year-old male from Manipur, India, presents to the ID clinic with 3-month history of low-grade fever, significant weight loss, and a generalized skin rash. On physical examination, he appears cachectic. There are generalized lymphadenopathy and hepatosplenomegaly. Dermatological examination reveals multiple discrete non-pruritic umbilicated papules with central necrosis of the face, neck, and the upper trunk. A skin biopsy is performed. The genes are stained reveals numerous small intracellular yeast-like organisms within macrophages. Some of the cells demonstrated distinct central transverse septum. So this is the image. So this patient is from Manipur, presenting with a disseminated picture, hepatosplenomegaly, lymphadenopathy, and there are some umbilicated skin lesions. And this is the biopsy from the skin. Okay, you can see some macrophages, and inside you have some structures. So which of the following is the most likely organism? The options included Histoplasma capsulatum, Cryptococcus neoformans, Talaromyces manifi, and Sporothrix shanghai. The answer here, so basically it's a disease which is endemic to Manipur, to northeastern part of India, and the answer here will be Talaromyces marnofi. This particular fungi was previously called as Penicillium marnofi. Endemic to the northeastern part of India, it can have a very similar presentation that of histoplasmosis. Histoplasmosis can have all the manifestation that I have mentioned in this particular condition, along with similar to that of Talaromyces. They can have lymphadenopathy, hepatosplenomegaly, even umbilicated skin lesions. If you look at umbilicated skin lesions in HIV patients, so there are a few differential diagnoses. So this includes molluscum contagiosum. So molluscum contagiosum in HIV can present in adults. They can be extensive, large lesions compared to the other people. So you can have histoplasmosis also can present as umbilicated skin lesions in HIV. You can have cryptococcosis presenting as umbilicated skin lesions, and then you have Talaromyces as well, which we have mentioned here. And then you have the mpox, which is now becoming common. So these are the umbilicated lesions, condition in which you can get umbilicated lesions in HIV. Now, why is this not histoplasmosis, and why is this Talaromyces? Is particularly if you look at the yeast. The yeast you can see here and here and here and everywhere has a typical transverse septa. So this is a typical appearance of the yeast of Talaromyces. So there is a septa in between. Okay, this is the characteristic histological appearance of this particular fungi. Whereas on the other hand, histoplasma also appears as a yeast. Okay, and it may have a basophilic staining at the center, in the area of the nucleus there, and you may have a pseudo capsule because of the shrinkage of the yeast. So it has a halo around it, separating it from the surrounding tissue. So it is the appearance of histoplasmosis. So if you have a septa in between here, you will diagnose it as Talaromyces manifi. So Talaromyces manifi can have a very similar presentation to that of histoplasmosis, that is disseminated histoplasmosis. You can have skin lesions, you can have bone marrow involvement, etc. So that's the answer here. So treatment is also same as that of histoplasmosis. You treat the initial period with liposomal amphotericin B, and once around 2 weeks, you can shift to oral itraconazole, which is the same as the treatment for histoplasmosis. Now, third question: a 45-year-old patient with newly diagnosed HIV infection, a CD4 count of 80, present to the emergency department with fever, persistent non-productive cough, increasing dyspnea over the last 2 weeks. HRCT shows bilateral ground glass opacities, PaO2 in the room air is 65, and staining for pneumocystis jirovecii is positive. So if you look at the CT, this is very characteristic bilateral ground glass opacity. It's like, oh, anyways, you are given the diagnosis. So what is the treatment of choice? Is it Septran? Is it IV pentamidine? Is it Septran? I mean, trimethoprim sulfamethoxazole plus prednisolone, or is clindamycin plus primaquine? So basically, it's PCP. Now, PCP, obviously, the treatment of choice is trimethoprim sulfamethoxazole. But the point is that when you have a PCP with a severe disease, okay, moderate to severe disease, you have to use steroids. And what are the indications of steroids used in HIV patients with PCP? Is a partial pressure of oxygen less than 70 millimeters of what? Mercury, or a PaO2 gradient more than 35. This is the alveolar to arterial O2 gradient more than 35. If these criteria are met, you are supposed to use steroids along with trimethoprim sulfamethoxazole. So the answer here will be C, trimethoprim sulfamethoxazole plus prednisolone. So this has to be kept in mind. If the PaO2 is less than 70, where it is 65, or the PaO2 gradient is more than 35, that's half of 70, you have to use steroids. So that is the answer here, trimethoprim sulfamethoxazole plus prednisolone. So already, like something that you mentioned, for severe PCP, the PaO2 less than 70, AaO2 gradient more than 35, adjunct glucocorticoid therapy should be used in addition to antimicrobials. First question, which of the following is not an AIDS defining malignancy? The option given are Kaposi sarcoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, invasive cervical carcinoma. Again, this is regarding the AIDS defining malignancy. So there are three AIDS defining malignancy. One is Kaposi sarcoma. Second is non-Hodgkin's lymphoma. Third is invasive cervical carcinoma. So the answer here will be Hodgkin's lymphoma. Hodgkin's lymphoma can occur in HIV, but it is not an AIDS defining condition. So there are certain conditions. It can be some infections, some other conditions, as well as malignancies which are AIDS defined. If these conditions occur, you will call the patient as AIDS. Not every HIV patient has AIDS. They will have AIDS only if they satisfy certain criteria. So among these, the malignancies, we have three: Kaposi sarcoma, NHL, and invasive cervical carcinoma. And Hodgkin's lymphoma is not mentioned in that. Just mentioned regarding the lymphomas that you can get in patients with HIV. The most common type of lymphoma that you get in HIV is the immunoblastic lymphoma, okay, and of which among the immunoblastic lymphoma, the most common is the diffuse large B cell lymphoma, okay. And some of the patients in HIV can also develop another form of immunoblastic lymphoma, which is called as the primary effusion lymphoma, which can present as effusions of pleural, pericardial, or peritoneal effusions with no mass lesions. And the Kaposi sarcoma herpes virus, KSHV, is also considered as the main driver in this particular condition. Sometimes there can be a solid variant of the primary effusion lymphoma, called as the plasmacytic lymphoma of the oral cavity. The other important NHL here is the Burkitt's lymphoma. Unlike the Burkitt's lymphoma that occurs in Africa, which is like the endemic African variant, so here, like in the endemic African Burkitt's lymphoma, EBV positivity is almost 100%, whereas in HIV, only 50% of them is EBV positive. Now, the third is a primary CNS lymphoma. It's always EBV positive, this particular condition. It has a median CD4, it occurs at the median CD4 count of 50. That is a very low CD4 count. So imaging usually shows 1 to 3 lesions, which are around 3 to 5 centimeters, and they are ring enhancing. They are a bit less enhancing than toxoplasmosis. Numbers also relatively are lesser compared to toxoplasmosis, but often it's very difficult to differentiate between primary CNS lymphoma and toxoplasmosis. Eventually, what you do is you do an IgG to toxoplasma, and if IgG is positive, you treat it as toxoplasma and look for response, because doing a brain biopsy can sometimes be very lead to morbidity in this patient. So the points, you have the AIDS defining malignancies, Kaposi sarcoma, non-Hodgkin's lymphoma, and invasive cervical carcinoma. And then you have, look at the non-Hodgkin's lymphoma, the immunoblastic lymphoma is the most common, of which DLBCL is the most common. In your Burkitt's lymphoma, only 50% is EBV positive. Then your primary CNS lymphoma, which can be EBV positive. It's a close differential diagnosis for CNS toxoplasmosis. Question number 5. Which of the following statement regarding acute HIV infection is not correct? This syndrome typically occurs 3 to 6 weeks after the primary infection. It mimics IMN, that is infectious mononucleosis. Opportunistic infection has been reported during this stage. Viral load is usually undetectable. Now, in this condition, this is basically acute HIV. So once you have this HIV infection, the HIV enters through the mucosa or the skin, and through like when there are like dendritic cells in the mucosa. From there, it is transported to the lymphoid tissue. In the lymphoid tissue, it multiplies, and when it multiplies, when it reaches a critical number, it is released into the blood, and this really like causes an immune reaction, and this immune reactions may manifest as a clinical syndrome. It is a febrile clinical syndrome very similar to infectious mononucleosis. They can have fever, they can have sore throat, they can have cervical lymphadenopathy, they can have atypical lymphocytes in the peripheral smear, they can have hepatitis. Very, very similar to that of IMN. So any IMN patient who is presenting to you and his heterophile antibody testing or the IgM viral capsid antibody testing for IMN is negative, always think of two things. One is CMV, and very important, second is HIV. Very, very important. You should never miss that. If an IMN patient is presenting a typical presentation of IMN and his uh, IMN testing is negative, do think of HIV. So it usually presents at 3 to 6 weeks. It mimics IMN. This particular condition, you can have a transient decrease in the CD4 count, and you can get even opportunistic infection. But if you look at the viral load, maximum viral load is actually seen in during this period. Actually, the viral load is not just detectable, it is a maximum. So you get very high viral load during this period. So this option is actually correct and not correct. And in fact, the answer for this question is D. Viral load is usually undetectable. Okay, so this you are asked what is not correct. So viral load is usually undetectable. This is not correct. Viral load is detectable. So this image you would have seen in Harrison, you would have skipped this. Basically, what it is showing is the pattern of CD4 count and viral load. So what is given in the blue or like the violet is basically the CD4 count. You can see there's a primary infection, and in the primary infection during that time, so around 3 to 6 weeks, there is an acute HIV infection. The CD4 transiently dips. Okay, and at that period of time, you may even get some opportunistic infections. And but then it recovers, and it take a long time, and slowly it declines. And when it reaches like around 200, okay, the patient becomes susceptible to various infectious conditions, and the patient has officially can be called as AIDS. On the other hand, if you look at the viral load, it goes to a maximum during the acute HIV infection period. Then the body's immunity acts on it. So the body's immunity will try to contain the multiplication. So the viral load will come down, but it never becomes zero. It continues to slowly increase. And once like you reaches the HIV, the AIDS stage of the CD4 counts become less than 200, it actually increases dramatically. So during all this period, you feel that the patient will not have any clinical symptoms. So this is years, like 8 to 10 years sometimes it will take. The patient will not have any symptoms. But you should understand that the virus is continuing to multiply. So there is clinical latency in HIV, but there is never microbiological latency. The virus continues to multiply. Question number 6. Which of the following best describe the mechanism of action of lenacapavir? Lenacapavir is so important. I mean, I mean repeating it always, but I feel it is important. It's a fusion inhibitor, it's a capsid inhibitor, GP120 inhibitor, integrase inhibitor. So those who have attended any of my previous classes or like own updates know that it's a capsid inhibitor. It's a first in class of the capsid inhibitor. This is the only capsid inhibitor that is now available. Now it is used, its indication is as a treatment, it is used for the treatment of highly resistant HIV along with other drugs. But its importance is not in the treatment, its importance is in its preventive aspect. So basically, it acts by binding between the P24 capsid subunits, and this will interfere multiple steps in the viral life cycle including nuclear uptake of the pro-viral DNA, the viral assembly and release, and capsid core formation. But in short, it's a capsid inhibitor. So it has been licensed for the treatment of individuals who are heavily treatment experienced and multi-drug resistant, who are not suppressed with current regimens. So, but more importantly is PrEP, that is pre-exposure prophylaxis. So previously we used to use tenofovir with disoproxil fumarate with emtricitabine. It's the oral pre-exposure prophylaxis, but it has to be taken daily. But now we have Lenacapavir, which can be given twice yearly injections. That is like every 6 months you can give injection. It has been proven to be effective in cisgender women, as well as we have trial research in other population as well. So this was published in NEGM. This is called as the Purpose 1 trial. And if you look at Purpose 1 trial, where they looked at two, like in these groups, they have Lenacapavir arm. Some patients received tenofovir alafenamide with emtricitabine. Some patients received tenofovir disoproxil fumarate with emtricitabine. And what is the response here? See, you can see that the background incidence of HIV, you can see per 100% years was 2.41 in the background incidence. Like those who did not receive any prophylaxis, it was 2.02 in FTAF, it was 1.69 in TDF, that is emtricitabine and tenofovir disoproxil fumarate. This is emtricitabine and tenofovir alafenamide. And look at it, Lenacapavir, 0 infections. So this is a very, very important landmark trial, Purpose 1 trial, the landmark trial in the history of HIV/AIDS. And this drug is going to change the entire landscape of HIV infection. It's available. We expect that it will significantly, if properly utilized, significantly reduce the HIV infection and pave a way towards our ambition of HIV elimination. But there is a lot of issues. It's a very costly drug, and most of the infections occurs in really marginalized populations. Unless we make this drug available to those populations, it won't actually make a difference. And that is what everybody would want to make it available to the developing and the underdeveloped nations of the world, where there is a high burden of HIV, especially in Africa. And we expect and we hope that this drug will actually be a game changer in HIV. Question number 7, which of the following statement regarding immune reconstitution inflammatory syndrome is not true? Some form of iris is seen in 10 to 30% of patients following the initiation of ART, which is true. Common in patients with high baseline CD4 counts. C, for patients with cryptococcal meningitis, it's recommended that they receive 4 to 6 weeks of antifungal therapy. Yes, it is very important. For cryptococcal meningitis as well as tuberculous meningitis, you always treat those conditions for around 4 to 8 weeks before you start on ART. And even if you develop iris, should you stop ART? No, ART usually is continued. But iris or immune reconstitution syndrome occurs in patients who have a low CD4 count. Okay, low CD4 count, they will have a rapid immune reconstitution. The viral load gets suppressed and the CD4 count starts increasing, which can lead to an inflammatory response. So the maximum risk of iris occurs in those with a low CD4 count. So that is the answer here will be B. So iris basically is a paradoxical response. So you have certain infections which may be masked in HIV patient because of the low immune state. So they can become manifest, or they may paradoxically worsen. So the iris can be of two types. There can be a paradoxical iris. So you may have a cervical lymph node due to a tuberculosis, and you start ART and suddenly the lymph nodes increases, a paradoxical worsening. Sometimes you will not see any clinical symptoms. When you start the ART, the patient suddenly manifests the symptoms, like they develop a new lymph node. So that's called as unmasking iris. So both these conditions can occur in patients, especially in advanced stages where they have very high viral load and low CD4 count, and not the other way around. So that's the answer there. Which of the following statement regarding Dolutegravir is not true? The first option is it's active against HIV-2. It acts by preventing integrase from binding the retroviral DNA and blocks the strand transfer step. Dose should be doubled when it's used along with rifampicin, and weight gain is a potential side effect. So the answer, so before you go to the answer, Dolutegravir is a very, very important topic because it's the backbone of the current antiretroviral therapy, which is followed in our country as well as worldwide. It is an integrase strand transfer inhibitor. That is correct. It is a very potent molecule. It can rapidly decrease your viral load. It has high barrier to resistance. It has very less drug interactions. but it has an interaction with rifampicin. If you're using it with rifampicin, its levels goes down, and that's why when you're using it with rifampicin, dolutegravir dose has to be doubled. Usually you give it as 50 milligrams OD dosing, or when you're using with rifampicin, you make it 50 milligrams BD. Weight gain can occur as a side effect. This is something that we have already discussed. The integrase inhibitors are active against both HIV-1 and 2. So this option is wrong, which makes the correct answer for the 8th question. So answer here will be A. Question number 9. A 38-year-old HIV patient with CD4 count, 45 cells per millimeter cube, presents with a 3-week history of progressive headache, confusion, and blurred vision. On examination, there is subtle mental changes, but there is no overt signs of meningeal irritation. Clinical suspicion of cryptococcal meningitis is high. Which of the following tests are most appropriate? Is it a CSF India Inc.? Is it CSF culture for cryptococcus? Is this cryptococcal antigen detection test in the CSF or blood culture for cryptococcus? Now, cryptococcus is a very, very important opportunistic infection in HIV, highly causes significant morbidity and mortality in HIV individuals, and occurs at a very low CD4 count, usually less than 100. So the options here are you're suspecting cryptococcal meningitis, and will you do a CSF India ink stain, which it's a fancy test, but you think that's the answer, but it's not the answer because its sensitivity is not that good, especially if the fungal load is not good, you won't get it positive. So that's not the answer. CSF culture. CSF culture is a very good test. It's a gold standard actually for diagnosing. It has the maximum sensitivity, but it will take some many days for the diagnosis to come. You cannot wait those number of days for the cryptococcal culture to be positive. The patient will die. Blood culture for cryptococci, no, you don't use that. It can sometimes be positive, but that is not the test. The test is cryptococcal antigen testing. So this test is highly sensitive, highly specific, and can be available within minutes. So that's the test. So the answer here will be CSF cryptococcal antigen test. Okay. 10. A 46-year-old newly diagnosed HIV patient with white corrugated lesions on the lateral aspect of tongue. The DNA which of the following virus is likely to be isolated from this lesion? So this is the image, and the options given are Epstein-Barr virus, cytomegalovirus, herpes simplex virus 2, and Kaposi sarcoma associated herpes virus, that is KSHV. So these are corrugated lesions on the lateral aspect of tongue in a patient with advanced HIV. Okay. So this is called as oral hairy leukoplakia. Now, this is a sign of advanced HIV, but the virus that drives it is Epstein-Barr virus. This is one of the multitude of conditions associated with ABV. So there are many conditions associated with many cancers and many diseases associated with EBV, and this is one of those conditions, oral hairy leukoplakia. Though the name is leukoplakia, it's not a precancerous condition. So keep that also in mind. So the answer, so here will be Epstein-Barr virus. So that's the 10th question. So 10 questions, as I already told, we had a very good participation. Around 400 of you have attempted these questions, and yeah, let me see if you have any questions here. Many of you have answered. I'm sorry that I didn't look at these answers, but thank you for all of you for joining. Actually, I hope this was useful for you. Thank you and good night.